Thank you so much for joining us today. I'm Selena Yong. I'm an associate editor at JACC, and I have the privilege of talking with Dr. Gilbert Tang today. He's a cardiac surgeon from Mount Sinai and is the first author of the full cohort 1-year outcomes of the Triluminate pivotal randomized trial. Dr. Tang, thank you so much for joining us, and congratulations to you and your co-authors on this important study.
Thank you. Thank you for having me.
Well, maybe could we start with you giving us kind of a high-level overview of what you found and the trial details?
Absolutely. It's my pleasure. So, on behalf of my co-authors, thank you very much for inviting us and getting this important study published in JACC. So, as you may recall, the first pivotal trial, the first 350 patients were actually published in last year in New England Journal of Medicine. And now we actually reporting the entire full cohort of over 570 patients randomized between the TriClip transcatheter edge-to-edge TEER therapy versus optimal medical therapy. And you can see that in now the paper also published simultaneously in JACC that overall the patients were elderly, they're around 78 years of age, with several comorbidities, including atrial fibrillation and prior hospitalization for heart failure. But consistent with the previous publication, we say that T-TEER with the TriClip system does show excellent safety profile with low adverse event rate, number one. And number two, the primary endpoint was met at 1 year with actually a greater win ratio favoring the device arm for the full randomized cohort. And the third point I want to make is that the primary endpoint remained driven mostly by the KCCQ score, but the win ratio was significant in across all three categories of the primary component. And finally, all secondary endpoints, significance favor the TEER group in terms of TR reduction, and also the 1 year KCCQ and 6-minute walk distance change, which is now reported first time that's also significant. And so I think overall the summary of this paper is that T-TEER with the TriClip system, at least in the randomized trial, does show an excellent safety profile with low adverse event rate and significantly improved functional outcomes.
Thank you, Dr. Tang. Do you think you could also explain to us a little bit more about the adaptive trial design, the rationale for it, and how it was conducted?
Yeah, absolutely. So, this trial, remember, was actually enrolled during the COVID-19 pandemic. We unexpectedly actually exceeded enrollment cadence faster than we expected. So with the adaptive trial design, you actually allow to see, in terms of the sample sizes for first look for analysis. And by the time we actually hit that landmark, we already enrolled over 570 patients, which is actually the entire cohort they're reporting here. So that's why we went back and looked at the 350, which was the predefined sample size. And we published that last year in the New England Journal paper. So this is now kind of the entire trial that we're reporting now.
And I understand that you did do some post hoc analyses comparing the earlier enrollment group with the subsequent cohort. Can you share if there was much that you gleaned from those analyses?
Yeah, no, thank you for bringing that up. There was an interesting observation that when we looked at the 350 patients cohort versus the subsequent, around 280 patients, the initial cohort did not show any differences in heart failure hospitalization in 1 year. But interestingly, at the subsequent cohort, there was a statistical difference in terms of favoring the device group. Now, as you know, tricuspid patients have a very heterogeneous and complex population. So we actually did a lot of deep dive, look at different subgroups, different predictors, and we didn't really find anything of significance, including learning curve, tricuspid severity baseline, whether, the number of devices being performed, etc. So we think that it might be multifactorial. Obviously, this subsequent cohort that was enrolled was kind of the second phase of this COVID-19 pandemic, kind of past that. So we're not sure if that has anything to do with it because, listen, there's been no real trial that's been conducted in this kind of scale for the first time. That happens during a pandemic. But what I will say is that, we probably need longer term follow-up to really understand whether this observation is actually real or not. So more to come.
Thank you. One of the things I want to highlight is one of the issues with this study was that because there was a control, but it wasn't a placebo control. And then you also have findings that the hard outcomes were not significantly different in the two arms. However, the softer endpoints like KCCQ and 6-minute walk distance were. You kind of did a deep dive on the severity of TR change with the improvements in those soft endpoints. And I think you were trying to get at, is this real? And I wonder if you could share a little bit more about that specific analysis.
Absolutely. So yeah, no, thank you for bringing that up. So yeah, there's been a lot of discussion actually when the trial initially presented about this, non-blinded study, because obviously if you're receiving a device, you're not pre-blinded. But having said that, people when they complete the KCCQ score or the 6-minute walk distance, that they were not told how much of a TR reduction they got. So interestingly, what we've seen is that there seemed to be the more TR reduction that you achieve, whether it's device or control group, you have a benefit in terms of KCCQ score improvement and also 6-minute walk distance improvement. Now, having said that, as you've seen in the presentation and in the manuscript, the device group has a significantly better in terms of TR reduction versus the control group, which you would expect. So what we've seen is that even when we segregate between the device group versus the control group, is the TR reduction, the magnitude matters. And that's what will lead us to believe, at least based on this trial alone, that there is some kind of physiological or biological effect of TR reduction with T-tier versus just a placebo, because otherwise you would have seen that, regardless of TR reduction.
Thank you. That's a very important point. I wonder if you can put this in the context of the other studies right now looking at transcatheter therapies for the tricuspid valve. We're seeing basically consistent findings across these studies that unfortunately we haven't seen improvements in mortality, heart failure hospitalization. However, the quality of life findings are really important. And I wonder if you could share your thoughts on whether we should be focusing more on quality of life and how to interpret this in the context of all of the studies so far.
Yeah, no, it's very interesting to see because, again, this is the first time, I think, in history that we have a randomized controlled trial compared to a transcatheter tricuspid valve intervention, whether it's repair or replacement. As you know, there's another trial being presented as a late breaker at TCT this year on replacement versus optimal medical therapy. So, and we also learned that patient with tricuspid disease is a very complex, heterogeneous population. So yes, despite maybe 1 year or 6 months outcome may not show a significant difference in terms of harder endpoints, maybe this patient takes longer for the curve to separate. We don't know that yet. Obviously, with mitral valve disease or aortic valve disease, we know that they separate quite early. But we know that the patient with tricuspid disease are kind of at the end stage or later, more advanced stage of the cardiovascular disease. So I think we'll have to see, whether longer-term outcomes will show a difference in some of these harder endpoints. But having said that, I think the fact that at least in the TRILUMINATE trial now, with the full cohort that are being published, in JACC, showing not just the soft endpoint, as you mentioned, by KCCQ score, which is subjective, but also more objective functional endpoint, which is the 6-minute walk distance, which has been validated to be a more objective functional assessment. That's reassuring to us that we know that if you fix TR and you improve the TR, as you've shown in our trial, the more TR you improve, the better you are from a functional status, both objectively and subjectively. I think it's a win for the patient. And I can tell you that during the trial, when we follow these patients, they can tell you subjectively, it makes a difference in their daily life. They don't have to go to the bathroom so often. They don't have to carry their quote unquote ankle weights anymore from all the peripheral edema. So in that sense, it's very gratifying to see.
Thank you very much. Beyond long-term follow-up, where do you think we go from here? What's needed next?
Yeah, I think the interesting aspect is to, how to make this therapy adoptable to the wider, population, both in terms of patient population, but also more important, the heart teams. As we know that the transcatheter tricuspid therapies are highly image intensive in terms of echo cardiographic guidance for these procedures. So I think we need to be able to democratize this to patients who need it to be able to achieve the same safety outcomes that we've seen in this particular trial in commercial use. So I think that is probably the next frontier. How do we do that as a cardiovascular community to make that happen, and also to educate the broader general community out there that tricuspid valve is no longer a forgotten valve, as we now appreciate. And so we need to get these patients evaluated sooner because, as you see in the randomized trial, and also in a single arm trial, in our trial, that certain anatomy beyond where the disease is too advanced, we really don't have a lot of less invasive or minimally invasive options for these patients. And so I think we need to kind of catch them before they go into that kind of end stage condition where we no longer have anything to offer. So we should evaluate these patients more proactively, in my mind, and also in the community to try to maintain the optimal medical therapy they need to be on to sustain the benefit of these interventions.
Thank you so much, Dr. Tang. Congratulations again to you and your co-authors on this really important landmark trial. We're thrilled to be able to publish it simultaneous with your presentation at TCT. Is there anything else you wanted to add or share about the study?
No, I just want to acknowledge, everyone on the TRILUMINATE pivotal trial team, in terms of all our co-authors and all the investigators, for helping our patients and, ultimately leading the commercial approval in April of this year, and now being able to offer a safe and effective, minimally invasive approach to treat patients with tricuspid regurgitation. So thank you to all our collaborators for this trial. And thank you, Jack, for publishing our paper.
Thank you. Thanks again for taking the time to talk with us today.